Great. All right. We are going to go in the order in which groups finished. So group number 4 over there, they were ready for all sorts of post-workshop entertainment. So I would like to invite the rapporteur for group number 4 to kindly share with us. Please identify yourself and your affiliation.
Hi, Mylin Tufte, part of the roundtable and from the North Dakota Department of Health. We had a great group, and I would say it's because we were efficient. So we had a very good discussion, and we thought the diagram was very complete. It conveyed a lot of cross-collaboration and cross-sector work. One of the things that we really liked about it, it helped us talk about the work that we were doing upstream in prevention and the policy work in setting up infrastructure and some of the system needs that we have. Some of the possible uses we saw for this diagram were to help us shift the culture and talk to decision makers. One of the things that we talked about on how we could use this diagram in our work to help propose policy and advocate for sustained funding. And that kind of led us into how we might adapt the diagram in the future. We thought that there might be a column that could be added on the cross-sector, and I'm using my hands to say that there would be a column that would be needed for resources. And we talked about sustainable funding, and there was a lot of discussion around that. And we talked about, for us in North Dakota, a legacy fund that sits out there and how to talk to our legislators to provide sustainable funding for tobacco prevention and control. Some other things that we thought that might make the diagram more useful for a specific audience was to really think about the patient and patient-centered needs and where does the patient sit in this diagram. Knowing that there are things that we as providers, other institutions or service providers may have thoughts about what's best for the patient or see from a community needs perspective, but if the patient is not activated or is not ready to change, that might not be successful. So having an understanding of where the patient sits within this diagram would be very important. Other things we talked about were adding consideration for transportation, and we just really enjoyed the discussion that we had within our group. Thank you.
Thank you. Any other members of the group that would like to add any other comments, round up? You did a fantastic job. Thank you so much. All right, so the group that was here, I think that was group number 3. Do we have a rapporteur? Please identify yourself and your affiliation.
Sure. Hello, my name is Benu. I am independent public health consultant based out of DC. Our group also had a very robust discussion about this diagram, so I'll run through some key points, trying not to repeat too much from what we just heard. But overall, we thought the diagram did a nice job of conveying sort of different places, downstream, midstream, upstream, that organizations could get involved. And also did a nice job of sort of demonstrating that regardless of your sector, that there are places at all of these levels to get involved and to push people to think about, how they might move upstream. We thought that the diagram as sort of currently written sort of seems largely focused on the healthcare sector. So thinking about it first, if your audience for this is in fact the healthcare sector, some things that we thought might be helpful to add or more explicitly call out were, things around community benefit and community health improvement planning, anchor institution roles, employee wellness, sort of some of these different things that came up during the course of today's conversation, where the healthcare sector has kind of a unique role to play, sort of figuring out, calling those things out more specifically here might be helpful to a healthcare sector audience as they're thinking about, where they fit in these different boxes, so to speak. So that was one thing we talked about. The other thing in terms of the possible uses of this diagram, we talked about it's useful certainly as a framework for thinking about where you are and where you want to be as an organization. Also could be useful for mapping partners across sectors, depending on what activities you want to engage in. We also talked about how it could be helpful as almost a work session document for community health improvement planning, things like that, to actually, write down what you're engaged in, what you want to engage in the future, who your potential partners could be. And to that point, in terms of adapting this diagram, we talked about how it could be helpful if you had sort of an electronic version of it, where if you scrolled over a certain piece of it, that there could be places for examples or partners, what sectors you could partner with in this particular area. So that, and then a few other things I wanted to mention. In terms of changes to make it useful for other audiences. So, we talked about how a lot of the jargon and framing is healthcare sector specific. So if you wanted this to apply to other community social service agencies or community-based organizations, that you might want to, change some of the language and some of the framing to do that. We also talked about potentially condensing the sector level and cross-sector engagement piece, where we have healthcare, public health, education, and housing. We thought, in addition to education and housing, there are tons of other sectors that have a role to play, and we thought maybe one of the categorizations we heard today was, public health, community care, and clinical care. So maybe some kind of framing that would streamline that, and also acknowledge that in addition to education and housing, you have criminal justice and you have environment and all sorts of other sectors that have a role to play here. That might be most of, I think, what we talked about. One other thing that came up that I'll just briefly mention, which I don't know that it has a place in the diagram necessarily, but we sort of were talking about kind of the bigger picture elephant in the room, so to speak, in terms of, the necessity of a diagram like this sort of stems from the broader social environment, capitalistic society, and the way that businesses in this country are structured and for-profit interests. And so just as, kind of background context to this, that's something that we talked about and I wanted to mention. But
Thank you very much for adding that context. Other members of the group that would like to add anything else? Thank you so much. Group number one. Who's reporting for group number one? The group that was here. Oh, Ernest.
Robust discussion, and there's no way I'm going to capture all the opinions in our group.
It's okay.
But we found that the diagram was potentially useful, but there were a lot of suggestions for other ways to think of this or to describe this. First of all, how it might be used to convince leaders to decision makers. So we heard that earlier. We endorsed that as one possible use. Secondly, to educate those that are more remote from the work and less familiar with it, so it could be useful in that regard, and to help particularly healthcare providers transition from where we are now to perhaps a new and improved future. So those are some of the potential uses. However, lots of suggestions for changes that would make it more useful for other audiences, and they include things like notations that financial incentives are currently limiting, and therefore it's difficult to move across those three levels for at least some organizations. We also acknowledge that many of the sectors that are represented on the current diagram are limited. It's missing, in particular, community members, some of the agencies that might be involved in the delivery of even medical services, things like YMCAs or churches. We felt that the roles perhaps could be better specified, and that is all the array of roles that that an organization could offer as a partner or a leader, whoever has the power in a particular situation. So that would be another way to enrich the diagram further. Next, we had a lot of discussion and various options for its positioning. Some folks were comfortable with the way it's displayed. Others felt that downstream should be at the top, since this is largely drafted from a healthcare provider's perspective. And yet there were more suggestions that perhaps it needed to be oriented on its side, beginning with key infrastructures, since that lies at the foundation of successful population health. There was a feeling that it misses some of the complexity of the work that's actually involved, and again, the interdependencies that are necessary for progress in advancing population health. And so there was a suggestion to add layers regarding those interdependencies. There was also a discussion around the distinctions between population health and health equity, which is in the title of the document, but some of us felt that those were quite distinct, and perhaps health equity was a part of population health, but they're two different things, and we may even need different diagrams to represent them accurately. Almost everyone felt that the diagram should, from the diagram, you should be able to tell a story and perhaps provide an example. And until it got to that stage, it may not be mature enough to be useful. That's my interpretation of the conversation, at least. Then there was a lot of discussion around the language that's used as well, and the importance of language when we're speaking to various audiences. That is, that health is not always a topic that resonates with audiences, that perhaps we should frame this in terms of thriving or wellness. Finally, how could you adapt this to an organization or a work? Again, a strong suggestion that we should be able to provide an example, tell a story. And then there was a discussion around at least 3 other models that can be used. We viewed this one as more developmental and used to mark progress, and perhaps taking a look at those other models would be helpful. And then finally, I think I covered all of it as best as I could capture it. But we had a very rich discussion, so I'll invite my colleagues to say something I didn't explain particularly well. You
turned it upside down, sideways, and you made it 3D. So thank you so much for that contribution. And last, but certainly not least, group number 5.
Glad I went after him because I think we did a similar thing. So I'm Melissa Crawford from Mathematica Group 5, had a number of folks. We spent a lot of our time, I would say, thinking big picture and thinking a little aspirationally about how this graphic could be used. So there were a few key components of how we thought this graphic could be used that drove, I think, a lot of our conversations around some suggestions for its changes or improvements. One of the most fundamental ones is that there was a need to really communicate a strong vision for what population health really is, and not necessarily just basing it on the history of population health within healthcare, and being big picture about it, and articulating in a very clear way the different levels of population health and how they are all fundamentally part of both population health and health equity. There was also a desire to really have this be something that could turn into a tool that could help different stakeholders and coalitions and partnerships to think through what they're trying to accomplish in their population health initiatives, and to really think about the various considerations they have to have as they're creating their programs or their interventions. And then we also thought it was important that this graphic convey the real benefits, the why of population health, both in terms of what kinds of outcomes you're hoping to achieve, but who those outcomes are really going to benefit, so that those expectations are very clear. So some of the suggestions our group had for how to make this more useful for specific audiences. So one thing we realized pretty early on is that talking just about upstream, midstream, and downstream is actually a little limiting. If you think about the water analogy, there's also the aquifer of all the root causes that are influencing these various population health efforts. And those are not just important to consider, but really where a lot of the fundamental changes can happen. There's also interconnectedness across all of these levels. So it's not like they're in sort of discrete buckets. You don't just have downstream actions. They influence actions across the entire landscape. So I think there needs to be a recognition of that. We felt it was important to convey who has accountability for the various actions. This is obviously a model that's very focused on the health systems, but in these partnership-oriented approaches, there's going to need to be accountability both within specific entities within the healthcare systems, but also outside of it, and a desire to be clear about that. And I should say accountability and incentives. What are the incentives to act? We felt it was also really important to focus on the root causes, not just in terms of the aquifer analogy in the root causes that affect population health, but the root causes of failure of population health efforts, so the things that, when you look historically at experience, that have caused initiatives to derail or be unsustainable over time, things like thinking through clear governance structures and good communications and IT and infrastructure. Those should be somehow conveyed in this graphic in a way that helps the people who are reading it understand their fundamental importance to the population health work they might be doing. And then the last, but I would probably say one of the biggest points that was raised is this figure as it's created is meant to really convey these concepts to more of a informed, almost research-oriented audience. Because of the work that population health is doing, many of us within the group felt it was important that it really convey the story of what population health is, and so it might be better to move away from more of like a logic model orientation into more of a picture similar to the efforts that have been happening in Westside United. Probably just mispronounced the name. No, okay.
Yes.
Something that can show the concepts that are important without necessarily needing to have it into a very specific, almost academic framework, and then have pieces beyond that that might help get into the other elements that need to be considered, sort of the other things that have to be considered when creating population health initiatives or examples of efforts that have happened, but letting all of it rest on that organized story of what population health is and how people should be working together to achieve it. And I'm sure I missed a bunch of stuff, but other people can chime in.
All right. And I love that you went to the aquifer. That was great. And that you also liberated the model. You put the populace back in population health. Thank you so much for that. And so I will take the prerogative of the facilitator to say that there's a new resource coming up by a partnership between the Beaumont Foundation and the Aspen Institute. It's called Phrases. And Phrases stands for Public Health Reaching Across Sectors. And it speaks, pun totally intended, about how do you speak about public health to non-public health folks in a way that is not imperialistic, but is rather inviting and helping people find their way. Thank you so much. And now, Josh.